Thank you for watching this presentation on ordering MRIs from the emergency department. We have had a challenge at our medical center with demand for MRIs outstripping supply in mid-2017, with as many as 41% of patients waiting for an MRI at midnight when the scanner is closed. We're working on multiple solutions. A second scanner is anticipated to be installed in a little more than a year. The business case has been made to keep the MRI staffed overnight. We're also looking at balancing supply and demand. MRI of the brain is the most common type of MRI, and many of them are unnecessary. It's also important to note that ordering and canceling an unnecessary MRI is not harmless. It disrupts an intricate ballet of 4 different transport services and many times results in a lost MRI slot. The biggest problem is patients' expectations. Once they know that an MRI has been ordered, it can be very difficult for the subsequent provider to cancel it. There is an ongoing rapid improvement event to improve MRI utilization. As part of that analysis, we've found that on average 2.5 MRI slots a day are lost due to lack of patient preparation. The nurses are working with a new MRI safety sheet, which you may have seen in Health Connect, and seems to be improving some of the problems. As physicians, we should be conscious of the fact that claustrophobia is a significant cause of cancellations, and remember to ask patients about it and treat patients for claustrophobia prior to their MRI if needed. Another important concern for physicians is that MRIs of the brain can take anywhere from several minutes to well over an hour, depending on what types of sequences are ordered. There is a new diffusion-weighted MRI sequence which only lasts a few minutes and has been installed from Region. Many of our sister medical centers are using it for stroke alerts. The standard MRI of the brain with T1, T2, and other types of sequences is useful for finding tumors or other structural abnormalities. An MRI of the circle of Willis is really only useful for a patient who cannot have a CT angiogram because it has less resolution. An MRI of the neck is rarely indicated because it has both less resolution than a CT angiogram, and ultrasound is a readily available and preferred alternative. This is the new workflow for a patient who presents with stroke symptoms. Initial imaging should be a CT scan with a CT angiogram. If the duration of symptoms is less than 4.5 hours, the patient may be a candidate for alteplase. If there is no large vessel occlusion, the patient will be admitted and a CT scan obtained 24 hours later. In the situations where an MRI is necessary, neurology has agreed to order it. If a patient has a large vessel occlusion, they may be a candidate for clot extraction and no further imaging is required prior to transfer. If the duration of symptoms is 4.5 to 24 hours and the patient has no large vessel occlusion, they should be admitted, and if it is needed, neurology will order an MRI. The patient with a large vessel occlusion and a long duration of symptoms is a candidate for possible clot extraction. To evaluate this, a CT perfusion study or an MRI with the short diffusion-weighted imaging sequence should be ordered as directed by the teleneurologist involved. The goal is to see if the volume involved is less than 70 milliliters and the patient's a candidate for clot extraction. If the patient is not a candidate for clot extraction, they should be admitted with no further imaging. In summary, an MRI of the brain really should only be ordered as part of a stroke alert for a patient with symptom duration of 4.5 to 24 hours and a large vessel occlusion on CT angiogram. The stroke alert diffusion-weighted imaging sequence takes less than 1/4 of the time of a regular MRI of the brain, freeing up slots for other patients and expediting care in the emergency department. It's also important to note that neurology will order MRI brains when needed for patients admitted to the hospital. Studies have shown that 26% or more do not need any additional imaging beyond the CAT scan at admission. It's also worth noting that an MRI of the circle of Willis is only needed for patients unable to tolerate contrast for a CT angiogram. An MRI of the neck is essentially never needed, a carotid ultrasound being the preferred study. The question then becomes, what about TIA patients managed in the CDA? This is the workflow for a patient with a TIA. All patients should have a CT scan to rule out hemorrhage, and a CT angiogram needs to have been obtained within the last year. For the majority of patients, the case should be discussed with neurology prior to ordering an MRI of the brain, and there is no need for an MRA. In the case of patients with an elevated creatinine or a contrast allergy who could not obtain a CT angiogram, they should go on to an MRI of the brain, an MRA of the circle of Willis, and a carotid ultrasound. Thank you very much for your attention to this presentation and helping us to wisely order MRIs.